Without further ado, Jessica and Phillip, please. All you.
Great, thank you. So I'm Jessica Kendall. I am the Outreach Director for Enroll America, and we are going to be tag teaming this presentation. So please feel free to interrupt us throughout the way, ask any questions that you may have. And this is my co-presenter, Phillip.
Fantastic. Well, you all have these lovely 3 cards in front of you, and you probably wonder what they are. So it's our little audience participation, and it works like a stoplight. Try to keep it simple. You don't have one? You can have mine.
And I have these for you.
Oh, fantastic. Look at that well-oiled machine. So we're going to ask questions throughout, and we're going to use the colors to figure out where you guys are on those questions. So if it's a yes or no question, green is yes, and red, because note cards don't come in red, they come in neon colors, and pink is the closest. So pink is no. If it's a question where maybe is an answer, or kind of, or somewhat, or we're trying, you can put a yellow in the middle. All right? So just to get started, we're going to just ask a couple yes or no questions. So if you are from a health center, please put your green card up. All right. If you're from a public housing or housing authority or other type of housing program, green card. Fantastic. And if you have the after lunch last session of the day, my eyes are droopy feeling in the back of your head, put your green card up. Fantastic. Well, I'm loud and maybe verging on obnoxious sometimes, so we'll try to do our best with that.
And please feel free to stand up throughout the presentation. I would rather see somebody standing up awkwardly than falling asleep. So feel free to stand up and stretch your legs. We have a long time together. So I'm Jessica. I am the Outreach Director for Enroll America. And to give you a little bit of background on myself before I launch into this, prior to joining Enroll America, I ran Oregon's outreach program for our Medicaid and CHIP program in Oregon. And during that time, we were able to cut the uninsured rate among kids and teens in Oregon in half within about a 1.5-year time period. We did that through running a really aggressive marketing and outreach campaign. So a lot of the references you're going to hear are me referring back to Oregon just because it was a place that I worked, and the strategy that we used there worked well, and we're really trying to bring that to the national level. So for the national level, Enroll America is a national organization. So grab your cards. Who has heard of Enroll America? Green card is yes. Perfect. Organization, and we have a very, very narrow mission, and that mission is to make sure that all Americans get enrolled in health coverage that's been afforded through the Affordable Care Act. And we're going about that through a couple of different ways. The first is we have a best practice institute. We are continually looking for success stories. What has worked in the past? What did people do, such as in Oregon, to get people enrolled into public coverage programs? And that could be getting enrolled into housing, getting enrolled into healthcare, getting enrolled into SNAP. What have we done to go find uninsured people or go find somebody who needs a resource, connecting them to that resource? And what have we done that's worked, so that way we can try to use those lessons learned to do the largest enrollment effort that has ever been done in our history. So the other thing that we're going to be doing is running a national campaign. And that national campaign I'm going to give a little bit more details about later. It will be in all of your states, but it's really a public awareness campaign. Part of the way that we're going about doing all of this is through partnering with every type of stakeholder you guys can think of. So we partner with healthcare-related organizations, pharmaceutical companies, hospitals, insurance companies, advocacy organizations, labor unions, employers, retailers. If you put our partners in a room together, they do not like each other, and they do not get along under any other issue aside from getting people enrolled in healthcare. And they only agree on enrollment for the sake of enrollment. It can be for altruistic reasons, for mission-driven reasons, or for financial reasons. We don't care. We want people enrolled in healthcare. So one of our fantastic partners is the Michigan Primary Care Association.
You guys probably know a little bit about primary care associations. There's one in every state. I'm from the PCA in Michigan. For the last probably five years now, I've been working with MPCA. We've had the pleasure of running the state's statewide outreach and enrollment campaigns for both Medicaid and CHIP for the last several years. And I also have the pleasure of actually representing health centers as an advisor administrator of CMS for outreach and education.
similar to Jessica, my background in outreach enrollment is in sort of getting people covered. So we, in 2011, ran one of the largest statewide campaigns that Michigan has ever done. We boosted Medicaid and CHIP enrollment 20% statewide in the course of 2 months. It was a fantastic experience, and a lot of the experiences that we have been working through our outreach and enrollment programs are now transitioning to training and technical assistance for health centers. So we have the opportunity to work with all of our health centers in the state of Michigan, public housing health centers, community, migrant, homeless, sort of all of the above. And then I also have the opportunity to come do things like this where we can talk about some of the things that we learned in Michigan, some of the things that we did wrong that we wish we would never do again, because there are certainly a lot of things like that too. And then, some of the things that we're looking forward to coming down the road. In Michigan, we have about 35 health centers, so we're sort of a moderate-sized health center state. There are many states that are bigger than us in terms of numbers of health centers, but I think we have some really good ones. So that's sort of our background.
Oops, this thing moves fast. There we go. So one thing you're going to see a lot during the next hour is this back and forth. And what I want to do is talk about the national perspective, because you all are from different states. And there's a lot happening nationally, and then every one of your states is different, and then your communities are different, and then you also represent different types of organizations. So I'll give the national perspective, and then we'll try to give really tangible, on-the-ground examples. If you tune out, the thing that I want you to remember is that you all have access to consumers, therefore there's a role for you to play. So if I'm talking about something that doesn't seem in your scope, that's fine. The goal is that there is a role for you to play in making sure that people get enrolled in coverage. So nationally, we will be having the Get Covered America campaign, and we actually staff in a handful of states around the country, and then we will have national staff that are supporting states to do their own enrollment efforts. And my best example I can give would be comparing Colorado to Michigan. So in Michigan, we just hired a state director and an organizing director, and Michigan has been doing tremendous work. They are a federally facilitated marketplace, which means that the feds are going to be running the healthcare system or the exchange to get people enrolled in coverage. So we will have a lot of people who are on the ground working to get people enrolled and making sure they get connected, that consumers get connected to groups like Phillip and to the health centers. Now, in a state like Colorado, you have so many stakeholders that are doing this work right now. You have a state agency, you have an exchange, you have all of these groups that are going to be reaching out to consumers. So our role in Colorado is really different than it's going to be in Michigan. We want to make sure to provide resources everywhere, but our national campaign will look different depending on the state that you're in. Yeah. Absolutely. That is a great question. So we'll touch on it a little bit. We are national. We are working in every state. And the state where we actually have staff tend to be the states that may or may not have a Medicaid expansion. So we've hired staff in Ohio, in Texas. Yeah, Ohio, Texas, Florida. We're hiring somebody in New Jersey and Pennsylvania. The common theme is there's a lot of uninsured folks, and the state is most likely not doing anything to get them enrolled. So we are working in all states, but we're really a national organization. And what our campaign will look like is will have a grassroots focus. We want to make sure that people hear that there's coverage available. So we're going to be spreading the word. We're also going to be using a lot of data to zone in on and figure out who do we think the uninsured are. So how can we use our resources wisely? And I know this sounds a little lofty and hard to pin down, and we're still working it out. But imagine that we're taking all of the data sources we can possibly get our hands on nationally that are publicly available and trying to create a framework of, in Colorado, who's most likely to be uninsured? Who are those consumers? What are those neighborhoods? So when we send volunteers out to go spread the message, we're not just trying to hit 10,000 doors. We're trying to hit the 5,000 doors that we think consumers are going to be at. So it's very data-driven, and we're going to be evaluating our work continuously. What that means is that if you're in a state where we have staff and you guys happen to be doing application assistance and you want people to come to you to get assisted, there's a lot of ifs in there, we want to make sure that we're connected with you locally. We want to make sure that we're providing you with whatever resources you need to spread the word that coverage is going to be available. We're also really coalition-based. It's essential that we are partnering with everybody who's doing this work on a regular basis, because there have been folks who have been working on this for decades, right? And it's not just about healthcare reform. It's about getting people involved in the coverage programs that already exist, like Medicaid and CHIP. So we're tapping into the resources that are on the ground. And then we also want to make sure that over the next year, we are sharing these success stories to really let people know, here's what the enrollment process is like. And once people can apply, here's the consumer that made it through the system and was able to successfully get enrolled. Because it's a lot easier to talk about the one person that doesn't get in than the 10,000 that did. So we're going to be building that narrative of success. And this is just another way to illustrate it. We will have earned media, we will have paid media, and we'll be having a strong digital and social media campaign. Everything with Get Covered America targets consumers. What we're doing with Enroll America is trying to provide you guys, organizations, with the support that you need to reach out to the folks you have access to. So the reason why we're doing this is because we look at what's coming as a huge opportunity. And that opportunity is that the Congressional Budget Office estimates that there are going to be 15 million Americans enrolling in health coverage over this next year. Does anybody have any idea how many uninsured are estimated to be in America right now? Depending on who you ask and what data source, between 40 and 50 million. There's about 50 million uninsured, about 40 are going to be eligible for coverage through the ACA. 100% of anybody, or of everybody, has never done anything. So what they're estimating is about 30 million will actually apply and get coverage. What they're also saying is that 15 million will apply within the first year, which is absolutely incredible, right? Over half the people who are eligible for coverage are going to apply within the first year. We'll talk about whether or not we really look at that is going to happen, but we know that in order for this to be a success, we need to make sure that more than 15 million people enroll. And I want to get us all on the same page of what enrollment looks like, just to kind of frame the conversation here. Let's imagine we're in a world and in a state where everybody has a Medicaid expansion, because that is just easier. As a consumer, regardless of your income level, there is a program available for you. So if you are an individual, if you're a single individual and you're making less than $15,000 a year, you would be able to get coverage for no cost. If you are a family of four making less than $30,000 a year, there would be a coverage program available for you at no cost. If you're a family of four making between about $30,000 and $94,000 a year, you would have financial help in order to pay for your health coverage. And if you make more than $94,000 as a family of four, you would be able to pay the full cost of the health coverage, but that coverage is going to be guaranteed coverage to cover all the health coverage that you need. So as a consumer, there's a program available for you. Now the Medicaid expansion makes this a little bit more complicated in a lot of states, because those would be the poorest of the poor, the consumers that make less than $15,000 a year, or the families of four making less than $30,000 a year. So it depends on your state, but the key thing is to know that because of the healthcare reform, there is going to be a program available. And this is old. Phillip and I had a conversation about this earlier today. You guys can identify your state. So the states that are in light blue are the ones that have a Medicaid expansion. In Washington state, they still haven't passed it, but the legislature and the governor are all saying it's going to happen. So this is who we're assuming will have Medicaid expansions. The middle blue is where you have a governor that's saying, we want it. It's debated whether or not it's going to get passed. And then the dark blue is, the M is probably not going to do that. I messed that up. The M is where there's a Medicaid expansion. The light blue is where there's a state-based exchange. And the dark blue is where there's a federally facilitated marketplace. So do folks have questions on this, since I completely explained it incorrectly? Yeah.
I'm from Illinois, so I know which one.
So you are going to be in a state-based partnership, and you are likely to have a Medicaid expansion.
So what's the light blue?
If you're having a state-based exchange. So this is where you...
Federal health?
What it means if you're having a state... Does anybody in here in a light blue state? Where are y'all from?
Congratulations.
Yeah. So for those states, what it means is that you all have money from the federal government to set up your own exchange. So they have federal funding, but it's going to be state-run. So in California, they have an exchange, they're passing legislation, they're creating all of the rules, and they received hundreds of millions of dollars from the federal government to do this. If you're in a partnership, if you're in Illinois, what that means is that you're sharing the responsibilities with the federal government. And if you're in a dark blue state, it means the feds are doing all of it. Yeah, so if you're in dark blue, what it means is that the federal government will be running all of this from 133 and above. They'll be running all of that, and the federal government will be responsible for it. From a consumer's perspective, the type of exchange you have is not impacted, right? It's from an implementation perspective that we all feel it. From a consumer, I'm going to a website to apply for coverage, and where that website is, if it's the federal government or if it's the state, it's still the government, and I'm going to be applying somewhere in order to get coverage. Y'all with me? Okay.
So let's really quickly touch on what happens when you don't have a Medicaid expansion.
Yeah.
Because I think Michigan's one of those states that might not have a Medicaid expansion. So this thing right here, this changes a little bit, and I'm actually going to use some cards. So the exchange, if you're in a situation where you don't have a Medicaid expansion, this 133 changes. So the exchange goes down to 100%, and then it ends. There's no coverage subsidies for folks in the exchange below 100%. So then you have your existing Medicaid eligibility level, whatever that is today, and then exchange coverage starting at 100%. So for people in Michigan, if we don't have a Medicaid expansion, that means that parents of children can be covered to 63% of federal poverty level, and then anybody could be covered starting at 100% in the exchange, and that means there's a gap. Now that's a tough thing to deal with, but it is something that we will all probably have to deal with. Maybe microphones, I'm not sure. It is something that some of us will have to deal with, so just keep it in mind, because it will happen, and Michigan very well may be one of those states, as probably will Ohio. Neighbors.
Well, and one thing to add to that, especially when you guys think of the folks that you serve, from a consumer's perspective, right now in all of our states, there aren't options for folks, right? And if you are a parent with kids in a lot of states, you're receiving messaging saying, get your kids on Medicaid and CHIP, and we're so sorry, but there's nothing for you. So this messaging game of how you reach out to some and don't reach out to others is complicated, and we're already doing that. So by no means do I want to say that this part isn't important, but what I really want to highlight is even if you don't do a Medicaid expansion, there are a lot of people in your state who don't have health coverage that will be eligible, and that's where we need to make sure that we're spreading the word.
So, when we saw this coverage opportunity coming, from a health center perspective, we said, what are the things that we need to do to get ready? What are the things that we need to put in place to actually capture this opportunity? And what sorts of strengths do we have that we bring to the table as programs that have been around for a really long time and know a lot of stuff and are pretty good at what we do? And we came up with this concept called the Outreach and Enrollment Playbook. And however corny it may be, the playbook is sort of a collection of strategies that are focused on getting prepared within your health center from a very operational perspective. So Jessica, kind of from the campaign, national perspective, this kind of stuff that I'm going to talk about in the playbook is, does your electronic practice management system actually spit out a report that's useful in targeting people that are uninsured? In context, there are sort of 4 things that you need to have for a playbook to be successful. This is a collection of strategies. You can use all of them. You can add your own stuff in. But no matter what you
do to put together your own group of plays, you have to have kind of these 4 pieces. So figuring out who exactly the stakeholders are for outreach and enrollment is important. We lumped people into 4 categories. So our staff, the people that are our patients today, the people that are likely eligible members of our community, and then our partners. And they all have different roles in this. Our staff have an extremely important role because they are the conduit through which we are going to talk to folks about coverage opportunities. The community members around us, so the people that aren't our patients today,
but are probably eligible for coverage. In the exchange, a lot of folks are eligible for coverage that have never been eligible before. We have a really important role in serving them as part of our service area as health centers. And then our partners have lots of interesting roles. They have roles as people that can help us get this job done. So resources that we can share, opportunities to work together, and also, ways to show leadership. So your position as an organization in your community, demonstrating leadership amongst the other organizations that you work with in ensuring that the folks around you are getting access to these services and to information about coverage. We think it's important that you have somebody who's in charge. That may seem really straightforward, but it's important to have somebody in charge. So with your cards, green for you have an outreach and enrollment lead right now, and red if you don't. Mixed bag, mostly green. So in a couple of months, if we were to do this again, I expect to see all greens. It's just like implementing an EHR or running an organization. Somebody has to be the person that's in charge. And with outreach and enrollment, it's maybe even more important because there are so many interfaces with other organizations and with different pieces of your organization that somebody has to be that central point. So you have to have a plan. We talked about this a little bit. Your plan can be in whatever format it makes sense for you. Just have one. And then the last piece is figure out how you're going to define success. Sure. So this is another great question. So green card if you filed a HRSA Outreach and Enrollment Supplemental Grant last week, and red card if you didn't. Mostly green, because if I saw red, I'd have to come right there. So HRSA has created some expectations through their supplemental funding. What HRSA said was number of people within your organization that are newly hired, number of people in your organization that are trained to provide these services, the number of people that you assist, and HRSA put out a definition of assist, so that's like educating people about options, talking to them about their new coverage, awareness in the exchange, and then they also said number of people enrolled. So at a base level, I would say use HRSA's definition, and then just because I never like to keep things that easy, I would add some of your own things into that. Think about measures like how long does it take for somebody to get access to an enrollment assister, just like how we measure the availability of appointments. Think about the quality of your enrollment assistant's work, just like we do patient satisfaction in health centers. Those are the types of measures that you would want to use to define what success looks like. And then in terms of benchmarks, that's something that's unique to the organization. I would say rely on your past experience and set something that's extremely practical because, and I'm sure you got this when you filed your application, practical goals are very useful. We shouldn't, shoot for the stars. We should set goals that are very practical based on our experience. And if we exceed them, that's fantastic. But set goals based on where you're at right now.
And for everybody who is not part of a health center, but partners with a health center, to tie that all together, what this means is that there's a really good chance that the health centers that you're partnering with have funds to do outreach and enrollment. So if your housing authority doesn't necessarily have the funds, but you have the partnership, what you can do is, one, hold them to the standard and say, we know that you have funds, here's ways we can partner. And if you somehow, and I think that every housing authority in every state is different in community, and I get that, but figure out what that relationship is going to look like, because one of the strongest, if you look at folks that are doing application assistance around the country, the strongest place that people reference as actually getting people to come in and help fill out an application is referrals. There is nothing better for an organization than referrals, because I go to my trusted source of information. I go to my housing authority. I go to the place that helps me with food, that helps me with some kind of assistance, and they find out that I don't have health insurance. If they say, go talk to Phillip to fill out the application, I am so much more likely to do it than by seeing a billboard and calling a 1-800 number, right? So that warm handoff and figuring out, if you're not going to do application assistance, or if you don't have the capacity, then how do you create that handoff to folks that can? And health centers now have a funding stream and are hiring staff to make those metrics that Phillip's referring to enroll people in available health coverage options. Make sense? So when we think about the people, like who are we actually talking about? Who are we targeting? Now this is national information, but what we've been looking at insured is starting out with where do they actually live? And for good and for bad, 2/3 of them live in only 13 states. So for California, y'all have about 7 million uninsured. For Texas, about 6 million. Florida, you're looking at 4 million. But I think what's really important to think about too is depending on your state. Anybody from Idaho? Okay. Idaho has almost a quarter of their adult population uninsured. So from a financial standpoint, probably not a lot of resources are going to go there. But if 1 out of every 4 adults is uninsured, the impact that it's going to have on the state of Idaho is huge. So even if you don't have a high number of uninsured compared to Texas or California or Florida, you may have a really high rate, and that's going to significantly impact your state, which should be a motivating factor to get people enrolled. So what we also know about the uninsured is that 1 out of every 4 speak a language other than English at home. And then we know that for those that would be Medicaid eligible, nearly half, 49%, so if I can just say half, haven't finished high school. 1/3 of the folks that are going to be going into the exchange haven't finished high school. So when you think about how we communicate the new coverage options that are available, and literally the materials that are out there, what they look like and what they say are going to be huge because we're looking at cultural issues, literacy issues, education issues, and we want to make sure that you are, if you are creating resources to move a message to talk about healthcare reform because you're so motivated from this, look to other organizations that have used consumer-tested materials to figure out what those messages are to really resonate with consumers. We also know that a majority of them work. So these are working folks that don't have access to healthcare, and we want to make sure that we're tapping into that when we're trying to reach consumers. So before I go to this next slide, I'm going to throw out some numbers, and I want to take a guess, and I'm going to make this more complicated. So everybody's green card represents 3/4, 3/4. Everybody's pink card or red card represents half, and the yellow card represents 1/4, right? So of those, what percentage do you think approximately of people know that there's coverage options available? All over the place. So what we found is in our national survey that Enroll America did, and this was in October, when it's the height of the election, so the height of propaganda, talking for good and for bad about Obamacare, when we talked about the coverage options available and asked if people knew, for those that are going into the exchange, 78% have no idea this is coming. For those that will be going into Medicaid, 83%. So no matter what we do, no matter what policies we develop, no matter what kind of system simplifications we design, it doesn't matter if people don't actually know about it, right? Because people don't apply for programs that they don't know exist. And I think that's going to be absolutely vital, and we'll touch on that in just a minute.
So one of the ways that you can actually apply these numbers that we've talked about a little bit is to get like a sense of within your organization, what does 83% people not knowing about coverage options look like? So I need a volunteer to tell me a little bit about their organization. And the little bit you'll need to tell me is how many uninsured patients you serve. Does anybody volunteer? Go ahead. 13,000. So I know it's towards the end of the day, but we're going to do some math. And I'm going to use a calculator because my 5th grade math skills are not so great. So what we're going to look at in terms of this number is 83% of our folks need coverage education. 13,000 example. 13,000
times 83% is about 10,800 folks.
So 10,800 people within your organization need education about their coverage options. What does that mean to you in terms of staffing? What does that mean to you in terms of partners? What does that mean to you in terms of the number of flyers that you need? This is why the math is helpful. It helps us pinpoint what we need. So let's go to the next example. So this is number of folks that we think are going to need to be enrolled, the number of people that really need enrollment assistance. Now, health centers nationally, a lot of the folks that we serve are eligible for Medicaid. So let's say the number of people within your organization that are eligible for Medicaid is 8,000? 7? 6? We'll go with 5. So you have 5,000 folks that are eligible. 75% of them want or need coverage assistance. That's 3,750 people. And we're going to divide that by 12 to see how many folks your organization needs to help sign up for Medicaid a month. Drum roll. 313. So per month. So 313 per month. What does that mean for staffing? What does that mean for the work that we need to do with our partners to help us with resources? I won't do the last one because it works exactly the same way, but it's about open enrollment. So this last one right here is the exchange, and the exchange works on an open enrollment period. So Medicaid you can sign up for any time. Open enrollment periods in the exchange are a fixed period in time at which you can enroll. So we're going to have a lot of folks that need help, except we're going to divide it by 6 because we have a 6-month open enrollment period to assist them. If you do the math for your organization, you can figure out what you need to get to. I'm not saying that you'll be able to do 313 by yourself a month in Medicaid or 500 a month in the exchange. I don't think that you'll be able to do that, am I right? That's a lot of people. Okay, so many of you can use the resources that you have around you to help you get to that point. So there are HRSA funds available to many health centers. There are organizations around you that have other types of enrollment assisters already. And think non-traditionally. So the health insurance exchange has a lot to do with taxes. And what's in every single one of our communities? Volunteer income tax assistance preparers that know an awful lot about taxes. So there are organizations around us that have folks that with experience and with knowledge, and we have to start working now to tap into those resources so that we can get to these numbers. But I would encourage you to do the math, because having a number is powerful. Having a number gives you an actual goal, so you know what you're working towards, and it's not something that is just hanging out there right now.
Just a super tiny clarifying question. Is the open enrollment, this open enrollment starts in October? That will be a
Great. Yep. Good question. So this first open enrollment period is 6 months. The open enrollment periods after that are roughly 2 months, month and a half. Yeah.
Yeah. So the first open enrollment period, what happens on October 1st, and sorry I don't have a slide to illustrate this, but with me. As of October 1st, every state around the country, consumers can go on phone. Let me just give you the visual. So as of October 1st, consumers will be able to apply online, over the phone, or in person starting October 1st, and they will be determined eligible for either the exchange, Medicaid, or if they have kids in the CHIP, and they'll all be auto-enrolled. That's the vision. Now for dates, it's October 1st until March 31st. If I apply on October 1st, follow me on this one, my coverage actually begins as of January 1st, 2014. So you can apply between October and January 1st, and when your coverage begins January 1st, right, it's like you can get your application in. So that's the first open enrollment period. The second open enrollment period in 2014 is the only year that this is happening. The second open enrollment period will be, I believe, October 15th through December 7th of 2014. Which means when we talk about getting 15 million people enrolled in the first year, we're actually talking about getting as many people enrolled in that first open enrollment period as possible. Now, to make it more complicated, if you're applying for Medicaid, and as a consumer, I have no idea. All I know is that I'm applying in one of these methods, right? So if I'm applying and I go into Medicaid, and my state has Medicaid expansion, then I can apply any time of year. So if I fill out this application online on May 7th of 2014, the vision is that my application will be accepted and it will say, you know, your coverage will begin during the second open enrollment period. And what I imagine is that I'd be asked to submit more documentation down the road. I would not be able to get coverage during that time. Does everybody follow me on this? I'm getting no's and a question. Okay.
What are the dates for the second enrollment?
So the first open enrollment period is October 1st to March 31st. The second one, I believe, is October 15th till December 7th. Now, where I think I lost a lot of you is what happens between March 31st and October 15th. And what happens is the websites don't shut down, right? And if I'm applying for Medicaid, I'm still going, let's say the website is enroll.gov, and I am totally making that up because it's not a real website. But if I go to enroll.gov between those two open enrollment periods, it's still active. They accept my application. Now, if I'm going into Medicaid, then I get coverage. If I'm not going into Medicaid, my coverage isn't going to begin for multiple months. So they'll keep my application, and that process of what it looks like is still being determined. So the key thing for consumers, and where this is really important for you because I just gave you a lot of information, the key thing to remember is we need to enroll as many people as possible during the first open enrollment period because after that it's completely confusing. So we need to enroll as many people as possible, and the message is to get everybody through the front door, right? Because if you have had experience in the past with trying to get people enrolled in public coverage programs, it's probably like that closed door over there. There are so many administrative barriers to getting people enrolled, and the goal, the vision for what's happening with healthcare reform is it's a lot more like this, where it is a streamlined process, where it is user-friendly, and from a consumer, I go to this enroll.gov, right? I go to this website, I fill out my information, have a seamless experience, and at the end, there's going to be a few options saying based on your income, based on where you live, here are some plans available to you. Which one would you like? And ideally, it should be that simple. What we see in October of this year will be different than the next year, right? October 1st is the beginning. It is not the end. So whatever we see on October 1st gives us a lot of room to improve things down the road. So regardless of whether or not your state does a Medicaid expansion, I want to highlight that there's a handful of decisions that need to be made, but regardless of what your state decides to do with this, you will definitely have a more streamlined process, and you will definitely have an exchange in your state. So without picking on any states, there are some states that have put up a lot more barriers than others, that maybe have 6 months renewals, that maybe have in-person interviews in order for people to actually get public coverage programs, and that's being eliminated. So eliminating the asset test, eliminating in-person interview requirements. If you are in Texas and you have a lot of these are going away. So for your current program, for those who are eligible for Medicaid currently, regardless of the expansion, it will be easier to apply and get enrolled. Which brings me to the unfortunate part that although we know that it might be easier to enroll, we also know, and we touched on this earlier, that if you don't know a program exists, you're not going to apply for it, right? It's the fundamental truth. So even if we have the best system possible, it doesn't matter. People aren't going to apply. Medicaid and CHIP is where we've seen so many outreach dollars, and we've only gotten to 84% because a lot of states still haven't taken the funding and really moved to enroll uninsured kids. In states that have, Oregon, Massachusetts, a handful of others, Michigan has been doing some great work.
4th highest in the country.
No competition, it's fine.
There's a competition.
We have better rates, but they have more kids, so it's complicated. But we're able to reduce it when you have aggressive marketing and outreach. So what it comes down to is these programs become successful when people actually learn about them. So that key thing comes back to you guys as the trusted messengers. It's either health centers or housing authorities that are continually talking to folks about their incomes. You become fantastic messengers for letting people know that coverage is available.
So we have our county hospital apply for the Medicaid year, which they were allowed to move forward now with a program expansion would, and different to what happened in Illinois, what they did is they selected a couple of the local FQHCs to participate in the program as providers and reimburse us at our PCS rate, which is a program that we're very thankful for. I bring this up because there are two of us. We are a healthcare for the homeless and public housing primary care. 94% of our patients live at 100% of the FPL and below, and 88% are uninsured currently. So we provide, for the most part, everything is provided free of charge to our patients. Student homes, we raise their co-payment, we pay for that. I mean, we've been fortunate to do that. I don't know yet. That's probably not. But we've been able to do it, fortunately. Our other FQHC partner is a more they're a general FQHC working for and have the more traditional side of PCL. What we have seen during this period is that we have had a really hard time. We hired 6 new outreach and enrollment folks. We had neat time giving her the app because we've been doing this. We've had a really hard time getting people to enroll because there's no real benefit to them because they get everything for free from us. And so to sit there, and we've tried, I've tried to spin the message in as many ways as I can say, you help us do more things for you. Because whereas our partners, when they're adding 50 grand to their bottom line every month in savings because of what they're able to pour into the county hospital. And this is our big fear for, almost 100% of our patients, if they do what they should do in Ohio, we have expansion, would be enrolled, and we'd actually have a reimbursement for us. But our patients aren't necessarily, they don't want to sign on a, they don't want to join another program, they don't want, it's kind of all of that. So I don't know if you guys, in your toolkit, have any best practices for Vermont, we have a state plan, and there is, all the first year, and even for those that are like truly, we're kind of known as the safety net and the safety net. I think, and the only thing that we thought of is we sat there with our board and said, well, can you increase your fees?
So I think
And you then write them off. We actually don't have a lot of that. So that's where this is the Medicaid donut hole.
I'll put my presenter hat on and then also my health center hat on. No, you're fine.
It's perfect timing.
It's awesome. So I think one piece of this is the individual mandate. So folks are going to be required to have coverage, and I totally agree with the skepticism around the amount of the penalty in the first couple of years. It's not enough to force people to get coverage. Where it's a safe space, we can all say that. So the penalty in the first couple of years is too low to force people to get coverage. However, when we look at the out years and the penalties are almost $700, you can get coverage as somebody at 100% of poverty level for less than the penalty. And in which case, that's a really high indicator. The other piece that we've talked a lot about in terms of actually helping people see the value of health coverage, which is really what we're talking about. So people seeing the value of health coverage are the things that they need to get that are outside the health center. And the concept that coverage can help them access the services that go on outside the health center. Health centers do a fantastic job doing primary care. Many of us do dental services. Many of us do behavioral health. But not every single one of us has a cardiologist on staff or an endocrinologist or a wide-bore MRI. And if we need those things, and patients do need those things, right? If you look at our patients nationally, they have hypertension, diabetes, COPD, asthma. They need those specialists. They need access to those services. Those are the things that coverage can get them outside of the health center.
And that's been the one, that's where this program hasn't helped us. And we had this countywide access program where you could go wherever you wanted. So if you wanted to go to the clinic and see a cardiologist there as an uninsured patient, we could get our patients there. If they sign up for the Metro program, they can only go to Metro. And it doesn't matter what income level you're at in Cleveland. If you're given the option between you can go to Metro and you go to the clinic,
yeah. So Medicaid expansion will look a little different.
One thing that we said.
Yeah.
That is right back to the hospital.
So, and then I'll just put my health center hat on for a minute and say, health centers, this is such an unpopular opinion, but I'll just put it out there. Health centers are not free clinics. That's not what we do.
I got a little bit right.
Yeah. So knock it off if you would. You're making it hard for the rest of us. So, I mean, I think that's, HRSA has put forward a program where we use a sliding fee scale to base payment on people's ability to pay and their family size. And if you guys have a sliding fee scale program where after they're through your slide, it's still too expensive, then your sliding fee scale program doesn't work. And you need to revisit that. And if they need to pay $1 or they need to pay $5, the concept is that they need to be paying something. And that's really, I mean, I think that's operationally where you have to come down on it a little bit, or we'll never be able to change that mentality. And just one other thing from the HRSA perspective is that you're actually, as health centers, required to help people enroll in coverage. It's a program requirement for health centers. So it would be an improper use of your 330 grant funds to cover care for folks that are otherwise eligible for a coverage program. Because that's using 330 grant funds to supplant care that could be funded with another source.
We're just in a funny bucket.
Yep.
It just happens that we started as a homework group. It just happens to be who we are. Trying to write history.
And it's a challenging thing, and it's a change. But I think that's the kind of illustrating the value of coverage, the services outside the health center, making sure folks are paying something, making sure that your sliding fee program is working appropriately. Those are all sorts of things that you can do.
I was thinking that it behooves us to try to enroll all of our insured patients which most likely be qualified for Medicare. Because then we get the grant money.
Yeah. That doesn't hurt, does it?
It doesn't hurt.
So as a PCA in the state of Michigan, we did a financial analysis to look at what the revenue would look like from all of the uninsured folks that were potentially eligible. And for our health centers in the state of Michigan, it was $47 million a year in new revenue based just in Michigan, just within the Medicaid program. So there's a mission perspective to getting these folks enrolled. There's a compliance perspective to getting these folks enrolled, and there's certainly a bottom line perspective, and they're all important. So we want to do it for the right reasons, but we also have a pretty serious financial motivator to getting folks into coverage.
And I want to jump in because I know we have folks that are not with health centers in the room. This is why partnering with health centers and tapping in to their bottom line makes a lot of sense. If you don't have the ability as a housing authority or an organization, if you don't have the ability, the capacity, for whatever reason, if you're not doing application assistance on site, they will be, right? So this is a fantastic reason, and Philip's about to go into some more information about ways that people can get enrolled. So take what he's saying and apply it to your own organization, or know that this is what health centers should also be doing. So it's a great way to tap into another resource.
Right, so I wanted to kind of dive into some of the things that we hope you guys can do, and then also things that we think you should be doing to help kind of get together and ready for coverage expansion. And the first one is incredibly simple but really important, and that's to actually know patient income information. So this statistic at the top right here is just really startling to me, but almost a quarter of health center patients nationally don't have income recorded in UDS. So UDS is an imperfect data source, but it's 23%. 23% of our patients don't have a patient income recorded in UDS. That's not going to work because income is such a driver for potential eligibility. Knowing income gives us so much more information about what somebody could be potentially eligible for, and it helps us really refine our outreach message. So knowing this information is incredibly important. So that's one of the things that your health center can be doing now. If you're going, your annual sliding fee scale application updates to be more rigorous in collecting income information, if you do, a pop-up supplemental question in your practice management system, that's something that you can do. There are a million ways of doing it, but getting the information before October 1 is really important.
And it's really important, to be honest, because if we don't know it, it's hard to proactively reach out and say to this person, hey, we think that you're eligible for a coverage, subsidy in the health insurance marketplace, and we can help you enroll. It's hard to say that if you don't know the information. So the second piece of this is patient contact information. So this is actually one of my favorite things to talk about, which I know is a little dorky. But green card is you think that 50% or more of your phone numbers are valid. Red card is you think less than 50% are valid.
Ooh.
Or they don't have them. Okay. Red cards. I see lots of red cards. So this red card is something that we thought we couldn't fix for the longest time. But it turns out we can fix it. There are like a million ways to fix it. So why do we want contact information? We want it so that we can reach out to people directly. And this is true health centers, housing authorities. If we have the ability to say to a particular person, we think you're eligible, and it's a personal message, our targeted outreach to them is more successful. There will be lots of opportunities for public education and awareness and outreach into communities, and those are really important things that we're going to talk about even more. But as a starting point, we should do a really good job with the people that we already know. So if your patients don't have a consistent phone number, what is a strategy that you can do to help them get a consistent phone number? Email. A lot of them have email. Even more of them have Facebook. So in Michigan, folks call this Obama phone, but there is, just like Obamacare, Obama phone. You have it too. We're not the only ones. Fantastic. So you're already doing it. So this is the number one strategy. So it is a low-cost cell phone program, free or low cost, that is run through wireless carriers. Some Assurance Wireless, SafeLink, those are all carriers that run this program. And if you are enrolled in something else, say you're enrolled in the SNAP program, you automatically qualify for this cell phone. So if they say they don't have a phone, or they don't have minutes, or they have trouble accessing, they have a burn phone that they change every 2 months because they get a new one, or they run out of minutes, or they're canceled on that carrier and they move to this carrier. I've heard all the stories too. This is a way for you to help them get access to a consistent phone. And that's a great thing. So that's strategy number one. You're already doing it. Does it seem to be working?
So if people want to know how to find out more about this phone,
which one do you use? SafeLink.
Another thing we do is personal home calling. Because those phones run out.
They do.
But, yeah.
Call earlier in the month.
Call on the 30th, we'll not get a hold of them. They'll call on the 1st, and then it'll be up. So that's another, that's a good idea.
And SafeLink is what I have used in the past as well. So if you just Google SafeLink, many of them actually do online sign-up forms. But if not, there are forms that you can print and then do them with the patient. So that's something that you can do to get prepared as well. The other pieces that you're looking for are contact information other than a phone number. So what is a way we can get a hold of people other than calling them on the phone? Can we record in our systems the fact that it's a mobile phone and get their consent to send them a text message? Stats on text messages are over 90% of text messages are opened, and most of them are opened within 5 minutes. That beats an email every day, and it certainly beats a letter. And it's also cheaper than a letter, because sending a text message is 3 cents, and stamps are 46 cents these days. So it's a cost-benefit proposition that's pretty high. Email addresses are certainly a wonderful thing. Traditional mailing addresses. Recording whether or not people are on social media. What might that do for us? So say every time a patient comes in, you ask them, are you on Facebook? You check a box. Once a month, your staff goes through and you friend those patients from your health center's Facebook page. Then what do you have? You have a way to send a message out from your health center's Facebook page that reaches all of those people on their mobile device, because that's where folks are using Facebook, is on their mobile device, wherever they are. That's a really powerful tool, and Facebook's free. Granted, a little bit of staff time, but it's definitely something volunteers can do. It's a perfect job for a volunteer. So think about the non-traditional ways that you can get contact information, and then make sure you're keeping it in an accurate way. And use the strategies. Use things like SafeLink to help people get access to something that's more consistent. And that's something that you can do before October 1 to help you get a hold of these folks when October 1 comes around the corner. To use some of the more technology-driven stuff, like sending out mass text messages or robocalls or whatever you need to get their consent. And that's something that you can do before October 1 as well. So actually get consent from folks. This is very easy to do, and I'll actually ask this question now, but green card if you have some sort of electronic patient information or client information system, and red card if you don't. Just about everyone? Yes, okay. So within most of your practice management systems, you can actually just set up automatic prompts for when somebody comes in for an appointment, they check in. The person that's checking them in can say, is it okay for us to send you a text message with information about this and that? That's something that you can do before October 1. This sounds complicated. Sending a text message is really no more difficult than sending an email, and it's extremely cost efficient. 3 cents versus 46 cents if we're just talking about the stamp, versus how much of somebody's staff time or hourly rate to call people on the phone. It's a very cost-efficient thing that people are reading, but you do have to get consent to use it. And if you're interested in some sort of consent language, we actually already developed it for you. So this is something that we're doing with health centers in Michigan and at PCA. And we developed example language that you can use to get consent from your patients, and actually posted right on PCA's website for the whole world to use. So you are feel free to access it. It's in our outreach and enrollment toolkit. Go ahead.
What was the stats on PCA?
Over 90% read and opened in 5 minutes, and most of them very quickly. And if you think about your personal experience, at least for me, when I get a text message, I read it right away. And I think that's how most people are, so it's not surprising that the stats would look like that. I would say I also said people are looking at Facebook on their mobile devices, and the stats also show that that's even more true for minority populations. So there's a pretty common misconception that folks from minority populations have less access to the internet or less access to social media. And what the actual truth is that they have less traditional access. They're not like using it on a home computer, but more of them have access to Facebook on their phone. And that's where folks are at. So I think another key piece of this is helping your staff get up to speed in advance. There are lots of things to educate staff about, and I know that that is like a constant challenge working in all of this information. What we would encourage you to do is to make sure that all of your staff just have some really simple background and they know where to give people more information. So if we look at the next slide, these are the things that we think most of your staff should be aware of. Not every staff member needs to know how to enroll someone. Not every staff member needs to know how to use the health insurance marketplace, but they should know a little bit about what's going on to your Medicaid program. So is our Medicaid program expanding? They should know a little bit about tax credits in the health insurance marketplace, enough to say to somebody, hey, you make under $94,000 for a family of 4, you're probably eligible for a tax credit to buy health insurance. And then, what are those health insurance benefits cover? And where do they go for more? That's the basic concept. So they need to know enough to carry on a 30-second to a minute conversation to get people a little bit of information and then know where to take them next. Now, I did a very infamous never to be published study where in the state of Michigan, we called 4 health center sites from every organization, and we said to the person who picked up the phone, I'm uninsured and I'd like to enroll in Medicaid. Can anybody tell me what some of the responses I got were? Go online was one of them. Okay, but not great. One of them was, this is a doctor's office, not DHS. One of them was, we don't do that here, hang up. I would venture a guess that I could do that same study in every state and have the same results, because not every staff member is up to speed on how they need to talk about this stuff. And it's just that little bit. It's just a little bit of information. We don't need every staff member to be an expert. We need them to know enough to very articulately hand somebody off. We need the person who answers the phone to know enough to say, yeah, you know what, you're uninsured. You might be eligible for some new coverage options. This is the type of assistance that we offer with enrolling in coverage. So you can come in to this address from 9 to 5 every day, or I can make you an appointment for somebody to help you get enrolled. That's what we're looking folks to know. And it's the person that answers the phone. It's your case managers. It's your providers. It's your medical assistants. It's your janitor. It's your board members, probably especially your board members. It's all of the above. That's the kind of information that we're hoping that they have internalized so that they can carry on those conversations when the time comes.
And just to reiterate all of this, we have Y Health Centers up here, and I know we're getting a little short on time, so we'll talk quickly. But it's not just health centers, it's that health centers have access to uninsured folks. And when you think of housing authorities, you do too, are desperately trying to find uninsured consumers, and you all have access to them. And aside from the fact that from a financial perspective and from a mission-driven reason it makes sense to do the enrollment, you actually have access to people's income information and their insurance status, which makes you uniquely placed to do either outreach and enrollment or do referrals to organizations that are going to be doing this. In every state, there are going to be a number of organizations that are desperately trying to find uninsured folks. So you have a lot of leverage in how you can capitalize on that. So if you don't have the resources, there's still a role for you to play.
So I'm going to skip forward just a little bit and talk really briefly about a lot of math again, but I'm going to do it quickly. And this is sort of, if you are in a health center, what's the return on investment? So you do all of this work to get prepared. You educate your staff. You get all of your data together. You hire these folks. What's the return on investment? So what we did was we looked at what's the cost of that sort of person's position. And at the end of the day, how many new patients does that mean? And how many more visits is that? And how much reimbursement does that equate for the health center? We're pretty conservative in our numbers, and I think you'll be able to see that because we did things like subtracted vacation time and sick time. We discounted productivity. We took into account that not every patient we enroll is going to stay at the health center. And what we found were you could enroll, one person can enroll a lot of folks if that's all that they do. If all they do is enroll people, they can enroll a lot of people. And if those people stay with the health center, it turns into a lot of revenue. Suddenly, your enrollment assister contributes as much, if not more, revenue per year than your providers. That's a pretty big deal. It's a huge deal
for health centers. Now, if you're not a health center, I think it's important to know that there is this social motivation to help people get enrolled, but there's also a real bottom line sense of this. The payer model of health centers has been strained for many, many years because we have so many uninsured patients. And this is the opportunity for you guys to fix it, to get these folks enrolled. Now, your reimbursement per visit may not be that high. It's just an average figure that I use. It could be higher. I know it's higher in many states. And I only used 3 visits per year, and the new UDS data says it's more like 4. So it could be more, it could be a little less,
But at the end of the day, investing your time and energy in getting folks enrolled has not only a positive impact for the patient from a health status perspective, it has a very positive impact on the bottom line for your organization.
And if folks in back can't see that, what it says is the potential revenue for one full-time enrollment person, if the patient goes to the clinic 3 times per year, is $409,000. So $409,000 for one full-time enrollment person, which if you have a local health center that is not doing this work, which is a lot of health centers, feel free to contact us. We can contact the Primary Care Association. From what it sounds like, a lot of what Phillip does as the Primary Care Association is help health centers figure this stuff out, right? We're all learning as we go, and you don't know what you don't know. So health centers are realizing that it makes a lot of sense to invest in outreach and enrollment, but that doesn't necessarily mean that they have been up until now.
And this is looking really just at the inreach, right? Just reaching your
Well, it's an enrollment calculation. So you could be enrolling the people that are already your patients or the people that are new
Referred
patients.
to you from housing authorities.
Yeah.
So did you, have you thought about doing a calculator that may also factor in the time required for the outreach and education assistance and all that? Because with this, which I love, you do assume that they come to you as you try to work on it.
Yep. We do have a separate model that we looked at that balanced FTE time between 60% enrollment and 40% broader outreach and assistance, which is what it looked like in most health centers in the state of Michigan. What it did was it cut this number in about half, but you were still paying for the outreach and enrollment position 2 to 3 times over, even if the person wasn't only doing enrollment. Yeah.
We just got our 10-minute warning, so I'm going to try to speak as quickly as possible here. So what Enroll America did, and I touched on this briefly earlier, is during the fall we did that national survey. And I want to talk about the survey results because we keep talking about the nitty-gritties of how important it is to do enrollment, but how do you actually do it? What do those conversations look like, and where are consumers at? So what we did with our national survey is try to identify where are consumers at. What do they know? What don't they know? Who do they need to hear messages from? What messages really resonate? And then we took all of our information and we did 2 things with it. One, we did a number of focus groups to drill down on populations that are more likely to be uninsured to figure out what messages resonate. And then we also took all of our data and we compared it to national surveys and to some state-based surveys that had been done. And that includes research that's been done by the Robert Wood Johnson Foundation, CVS, Blue Cross Blue Shield, the California Exchange did a bunch of research. And what we found, and state-based, regardless of where you're at, overwhelmingly, people want health insurance. Which might sound like, oh, duh, but it's kind of revolutionary when you start to think that we don't have to sell the value of health insurance to most people. They want it. But what they think is that they can't afford it. And if they can afford it, it's because it's not a very good plan. And that's that circle we need to get past, right? Like, I want health insurance, it's important, I can't afford it, and if that's something I can't afford, it's not going to cover the care that I need. So what we also wanted to know was, well, when you've shopped for health insurance in the past, or when you tried to get it, what is that experience like? Because none of us do things that we don't like doing very well, right? So how do you feel, or how did you feel when you were applying for health insurance, and how do you want to feel? So what's that difference? And how they feel is stressed and frustrated and overwhelmed, which goes back to why would they do that? Why would they go do that again if it felt so terrible? But when we asked how they wanted to feel, they want to feel confident and in control and insecure. So when we told them about the new coverage option, knowing that 78% had no idea this was coming, and when we told them about it, overwhelmingly, people are interested in learning about it. They want health insurance. They're excited to know that there's going to be a coverage option available for them. So what we also did was we took our pool of uninsured and we broke them into 5 different groups. So we did a lot of segmentation. And for example, I live in Washington State, and I'm from Oregon. So I'm from the Northwest, I have brown hair, and I am a woman. So you could put me in any of those categories. I'm a woman, I'm a brunette, I'm from the Northwest. And what we tried to do is look for those 5 themes of the uninsured. So one of them would be, women who have kids in Medicaid or CHIP, right? So there is a dominant group of uninsured folks out there who have experience with Medicaid, so it's not that hard of a sell to talk about getting a public coverage program. There's also a group of folks out there who are uninsured and who are sick and who have been waiting for coverage. And then there is a huge group of predominantly young men who are less educated, who think that health insurance is unnecessary and they are not interested in it. And what we looked at with all these different groups was, okay, if you're going to hear a message, who do you want to hear it from? And for that group of young men, they want to hear it from their mom. And we said, well, who do you go to for information? They said their moms. So this group becomes their mama's boys. So we don't need to reach out to those young men. We need to reach out to their mothers, right? We will never be the trusted source of information. But what we found is these 4 messages put together reach 89% of our population. So no matter what segment those people were in, right? If you use these 4 messages together, this is going to reach 89% of your population. So if you tell people that health coverage is going to be available that covers all of the care they need, like prescriptions, medical visits, prenatal care, emergency room visits, so that gets to that point of I don't trust that my care is going to cover what my insurance is going to cover what I need. So if you tell them that, and that there may be financial assistance available, all of a sudden it becomes a little bit more affordable to me. And I'm not going to be denied because of a pre-existing condition, which hits for all of those that have had negative experiences in the past. And then highlight the fact that the insurance plans will have to show the cost, and there's not going to be any fine print. Because I've had to shop for insurance between jobs on my own. I have a master's in public health. I have been working in healthcare for the last 4 years, and I had to do this last spring, and I had no idea how to choose a plan. I'm overeducated. So how do you take, somebody with 2 kids and a couple part-time jobs who's really busy and send them online and shop around? So letting them know that that option is available and that using these 4 messages together, it will reach 89% of your folks. And if you throw in that extra little fact and you can go down the hall and talk to Natasha if you want help applying, or you can call Natasha at this number. So for all those health centers that answered the phone, all I want that receptionist to know, if I call, is these 4 lines, and that call Natasha, right? That's all I need them to know. And I think that this is your baseline. This is what everybody that we talk to in any organization, this is all they need to know, and then you can decide the level of assistance you want to provide from there. So speaking of providing assistance, Phillip touched on this earlier. For good and for bad, we said, great, we know who you want to hear the message from. We know you want to hear the message. We know you're interested. We've told you about the options. Do you want help applying? And overwhelmingly, people said yes. 3 out of 4 people said yes, they want help. And yes, they want it to be in person. And what I think this is people are frustrated and confused, and they want to know that there is a live person to talk to. It doesn't mean that you're going to have that many people turning to somebody for application assistance. What it means is that I need to know there's somebody I can turn to if I need help. And by knowing that, I'm going from being confused and overwhelmed and scared to actually feeling secure and confident and reassured in my decision. So this kind of goes into where help can be provided. They want it in person, and providers are who they trust. And it's not that you spend your 20-minute visit with your provider talking about how to get coverage. It's that when I see white coats and scrubs, I really can't tell the difference between anybody. And it makes sense to me to talk to the person that I think I'm paying for care about how to pay for my care, right? Like that makes sense. Just want to reiterate the fact that getting assistance helps people get enrolled, and it makes them feel confident. And every survey that we looked at found the same similar points.
So these presentations are going to be posted on the conference website, and we included a pretty significant in here to help you guys think about what you're going to do next. So
hopefully we've sort of sold you on the concept that there's a really great opportunity for you to invest in outreach and enrollment. And when you go back to your health center, there are all sorts of things that you can do and put in your playbook, put in your plan. These are some of the options that you should think about. So how are your folks going to get trained? That's one thing. Developing a consistent enrollment process. So every site of your organization, every staff member that helps with enrollment does it the same way.
And it's done in a way that can be verified for quality assurance. I sound like a telemarketing recorder. But I can tell you that at MPCA, 98.9% of our clients would refer us to their friends and families because I asked them about it and I followed a particular process. I can tell you how many of them thought my staff treated them with respect. I can tell you how many of the people that we enrolled thought we gave them enough education about what their coverage covered. I can tell you all those things because we followed a particular process and we did quality assurance, which is the next thing. So think about that as part of your plan. Look at the entry points to your organization, so all of the different ways that people get in, the phone calls, the case managers, the outreach workers. If you send preventive service reminders like, hey, it's time to get your kid's wild child visit, look at all of those opportunities to touch people and deliver this message. Look especially at your financial process. So this seems weird, again, like the billing people would be the last folks that you would think were doing outreach, but the billing people are the ones who send statements to people that have a balance they can't pay. And the billing people really want to help people with that balance. They want to give people options, and they're a powerful group, and it's also a really important set of process for getting this information out to your population. Look at your waiting rooms. Look at your patient visits. Think about all of the opportunities that you have to work in this kind of information in different ways. Know that it doesn't need to be the provider. It doesn't need to be the doctor or the nurse practitioner or the nurse or anybody else. It needs to be somebody that works there, and it has to be done in a structured way.
And just to highlight real fast, because we've spent so much time touching on what health centers can do, in every state right now, these outer bubbles exist, right? There are people who are providing application assistance. And you guys might be part of the community-based groups or the consumer assistance programs. There are people providing application assistance everywhere. This is the new option inside of health reform. Navigators most likely will not be health centers. Small chance that they will be, but overwhelmingly they're probably not going to be. These are a group that are receiving either state funds or federal funds to help people do application assistance. So if you're not partnering with your health center, there's going to be some kind of organization locally that is applying for funds, who is looking for uninsured folks that would love to be partnering with you. And then if you're not close to a navigator, if you're looking for other groups, these are two different types of entities. And really the main goal with this is to say that there's the opportunity, both paid and unpaid, to do application assistance and ways to receive training. So going way beyond health centers, looking at chambers of commerce, Rotary clubs, employers, small businesses, community-based organizations, any entity under the sun, there is a place to get application training in order to help consumers enroll. And we have 1 minute. Go.
So I'm just going to skip forward a little bit.
Sorry, guys. We had a lot of play. We had a lot of information.
And half of the reason that we made the information available is so that you can take it home. So questions for you to ask yourself. I'm really big on probing questions, if you can't tell.
I don't like to give people answers. I like to tell them the right question to ask. I've learned things in 5 years at a PCA. We have to ask the right questions of ourselves. I think the bottom line and kind of the most important piece that we want to put out together is that this is not going to be successful unless every single one of our organizations is playing a role. And there is a role for every single one of our organizations. If what you feel like you can do is learn a little bit about coverage options and distribute material and refer people to the folks that are doing the enrollment, awesome. Mm-hmm. That's a really important part of this work. If you feel like you can be the one that's doing the enrolling, great. If you feel like you can be the one who is doing everything from finding somebody in the community to getting them in to see a provider, fantastic as well. But there is a piece for everyone, and there are a lot of resources out there to help you do it. So look to your cooperative agreement partners, look to your PCAs, to your national cooperative agreement partners. There are a couple in this room. Look to Enroll America. Look for the resources that are out there to help you achieve that role. And if you haven't already started this conversation of putting your plan together, what pieces of that plan should be there, who's in charge, have that conversation now. Because a month from now,
is really when your plan should be working. That's the goal, educating patients at the end of June. So have that conversation when you get back if you haven't already started it.
And on, two more. There we go. Well, on the last slide, if you go to the Enroll America website, you can click on a map of the country, click on your state, and we are trying to make it as easy as possible for you all to get resources and information of how to do this work. So if you want to know what's happening in California, we have links to the California Exchange, we have links to the outreach plan, we'll have the information as soon as it's available of who's awarded the grants. We want to make sure that you can partner locally with your other organizations, and it's at enrollamerica.org. If you want information about the campaign, go to getcoveredamerica.org.
Great, thank you guys so much. Quick reminder, if you have not filled out your surveys already, please do so. I'm going to turn them in to myself, to Marisa, who will be collecting them. Also, if you want to